Assalamualaikum. My name is Dr. Hassan. Today we are presenting the remaining presentation of fundamentals of robotic surgery in urology, strategic placement of team and equipment in which there is a surgeon console and on the patient table side equipment cart, scrub nurse and the anesthetist. Where we are showing वीडियो इसको मिनिमाइज करना वीडियो के लिए This is a Perseus robotic system which we are using in SIUT nowadays. The second video.
Surgery itself is scary. When I was training, pretty much all the surgery we did was through big incisions. And even if you had to deal with a small area in the body, you still had to make a pretty big incision to get there. Right away, I realized there's got to be a better way.
To do an open surgery, you have to stick in your hand. With a single port, you don't have to disturb all that tissue because you are going right to the source.
Single port is a robotic platform that enables surgery through a single incision or natural orifice.
It's allowing us to do surgeries differently than we did with the multi-port. That's the key to this.
By providing the ability to access anatomy in different ways, we're really setting up the potential for improved outcomes.
What every patient wants, they want to get back to their life. Single port robotics is allowing us to get them to that point, and that is really exciting.
You're good to go? Okay. The really exciting thing about davinci single port is that we're providing surgeons with another tool in their toolbox. Traditionally, surgery is performed by accessing the anatomy through multiple incisions. Single port enables that same type of procedure through a single incision. The unique capability is that once in the body, the instruments and the endoscopes can articulate. So you see you've got triangulation at the camera and you've got triangulation at the elbow joint in addition to the wristed articulation. When we launched SP in 2018, what we found
This picture shows the strategic placement of a team and equipments versus robotic system, a surgeon console on which surgeon controls the control hands. From these control hands, electric movements which control these robotic arms which are placed at the bedside unit. This versus robotic system. The surgeon console on the main console scene which surgeon perform see the hand controls and arm rest, and this is a bedside unit. This is a card and arm performing procedure which we create the pneumoperitoneum. Approaches closed technique varies needle and the open Hassan cannula technique too. Approaches में transperitoneal approach and retroperitoneal approach. Closed technique varies needle, at which side varies needle puncture commonly inserted at the umbilicus on the right or left lower quadrant. If patient lateral decubitus position, two finger breadth medial and superior to anterior superior iliac spine. Insert the needle at a 90-degree angle to the skin. The depth of insertion should be adequate, typically around 1.5 to 2 centimeter. Assessment में aspiration, irrigation, aspiration test for the where is needle. Connect the needle to a pressure monitor. A drop in pressure indicates entry into the peritoneal cavity. If pressure monitor pressure drops, then it shows that a varus needle is into the peritoneal cavity. Begin inflating CO2 into the abdominal cavity, typically at a pressure of 12 to 15. This open Hassan technique skin which we are using now in most commonly in skin incision at the umbilicus about 1 to 2 centimeter. Open the fascia, make a small incision in the fascia access to the peritoneal cavity. After visual and digital confirmation of peritoneal cavity, we can insert introduction of trocar. Insert a trocar, a sharp hollow tube directly into the peritoneal cavity through the incision. Start inflating CO2 gas into the peritoneal cavity, same pressure. Retroperitoneal approach. Patient is typically placed in a lateral decubitus position. A flank incision is commonly used, typically around the 11th or 12th rib. Dissect through the skin, subcutaneous tissue, and gases which we are using. Most commonly, we use CO2, and it is non-inflammable, highly soluble in blood, easily removed, expelled through respiration, inexpensive. Other gases use nitrous oxide and helium. ये ऊपर वाला ही है, ऊपर पीछे बैक, एक स्लाइड बैक. Surgeons are seated at a console, view the operating field via a binocular device, and place their hands in the master hand controllers, which can translate the movements of their hands into an electric signal, which travels via a cord to the surgical card and activates the robotic arms. These masters can be modified to adjust the ratio of motion of the surgeon's hand to that of the robotic arms. Hand controls which surgeons used at the surgeon console. With these movements controls the robotic arms. Robotic arms located on surgical cart are attached to surgical instruments through a robotic instrument adapter. An 11 mm telescope is connected to the central robotic arm and contains two 5 millimeter telescopes producing 3D vision. Physiological consideration in adults: choice of pneumoperitoneum, keep pressure between 12 to 15, no change in cardiac parameters, reduced post-op pain, and marked reduction in oliguria. Effects on central system up to 20 if we keep pressure 20 mmHg, and if hypovolemic, a deep venous return, increase compression vena cava, and if hypervolemic, increase venous return and increase compression of vena cava. Above 20, capacitance vessels are collapsed, increase vascular resistance and decrease blood flow and decrease venous return. Physiological consideration involves in the which effect on the respiratory effect, pressure effect, increase intra-abdominal pressure, diaphragmatic motion limited, increase alveolar dead space, decrease lung volume, and average peak airway pressure needed to be increased to keep tidal volume constant. Non-pressure effect may head down position may cause pulmonary edema. Effect on renal: increase intra-abdominal pressure, significantly decrease urinary output, keep or less to avoid oliguria. Pressure to keep pressure will be keep 10 or less to avoid oliguric state. Use of we basically use furosemide. Acid-based metabolic evidence: hypercarbia, respiratory acidosis, absorption of CO2 via peritoneal membrane can be dangerous in COPD patients, which we are previously discussed in the previous presentation on the indication and contraindication. Physiological effects of pneumoperitoneum: cardiovascular में decreased cardiac output, increased systemic vascular resistance, increase or decrease the blood pressure. Respiratory effects में functional residual capacity decrease, noise decrease, airway pressure increase, perfusion ventilation mismatch increase, and the pulmonary vascular resistance also increased. Gastrointestinal gut blood flow decrease, risk of regurgitation of gastric contents increase, renal glomerular filtration decrease, cerebral intracranial pressure increase. This is previously complications may obtaining the pneumoperitoneum, which is a closed technique or open technique. This causes these complications, which we are discussing further. Related to insufflation, bowel insulation, asymmetrical abdominal distension followed by flatus. Barotrauma causes prolonged elevation pressure and increase in ventilation pressure, first second hypertension. Gas embolism, blood vessel or organ, acute cardiovascular collapse, dysrhythmias, tachycardia, cyanosis, and pulmonary edema. Subcutaneous emphysema varies needle leakage of CO2 around ports, which cause the subcutaneous emphysema, and crepitus over abdomen or thorax.
Wait a minute, Asan. Can anybody told me about how we can diagnose gas embolism and how we can treat gas embolism on the table? Radiography. जो best test है diagnosis for to diagnose the gas embolism, and parameters basically decrease blood pressure, tachypneic. These are the signs of gas embolism, and how we can treat this patient if the patient is on the table.
Head side down, the tendon and butt position.
Second, first is Second, large bore cannula to aspirate the gas embolism. Second. And third is hyperbaric oxygen, hyperventilation. So these are the things. Listen, previous slide, bro.
तो एक टर्म आया कोई मास्टर हैंड कंट्रोल कुछ इस तरह का टर्म था
जी सर
अच्छा उसको कह रहे हैं मास्टर हैंड
सर
we have done the transesophageal cardiography, okay, echocardiogram. So what are the factors, whether the pulmonary artery pressures increase or what happened to the patient? So how we diagnose on the basis of this? Whether we diagnose or we have assumed that this patient has gas embolism. So whether it affects gas embolism effect on the pulmonary artery pressure or not?
No, we can't accurately diagnose on the ECG parameters.
मैडम शेरी आप कुछ ऐड करें आगे आ जाएं सीनियर्स को आगे आना चाहिए यार दोनों कुर्सी रोज खाली आ जाएं आगे थोड़ा और कुछ बताएं हमें कि कुछ ऐड करें कुछ नेगेट करें नहीं सब ठीक है क्योंकि हमें तो पता है नहीं आरिफ साहब जो बोल रहे हैं हम कह रहे हैं सही है हाँ मैडम शीरी कुछ ऐड करें
Q3 पैटर्न आता है ठीक है एम्बोलिज्म में चाहे फैट एम्बोलिज्म हो चाहे पल्मोनरी एम्बोलिज्म हो मगर अगेन ये बहुत ज्यादा जो है ना बहुत कम परसेंटेजेस में आता है 1 to 3%. So if we are suspecting any kind of embolism per operatively on table, we have to see if the patient has suddenly become tachypneic, tachycardic. I mean, this is the earliest sign that something bad has happened to the patient. Rest of the signs फिर हम late follow करते हैं.
सही थैंक यू और सखर से हमारी टीम रोबोट टीम कौन कौन है कोई मदर साहब आप कुछ फरमाएं
तो डॉक्टर शीरीन सही कर रही हैं tachypneic tachycardia is the first sign of pulmonary embolism or gas embolism that is the first sign to catch up the patient for diagnosis
ठीक
What are the further investigation if you are suspecting the pulmonary embolism? Further workup.
We are for the diagnosis, accurate diagnosis, we can do transesophageal echocardiogram. But on the basis, we can do ECG per operatively. We can take help from anesthesia and cardiac, our team, to help to reach the diagnosis for this patient.
So basically, it's a clinical diagnosis. To diagnose a patient on table, we have to diagnose it clinically. Otherwise, rest we can follow up later by doing CT angiogram, 12-lead ECG, cardiac evaluations, ABGs. We can do it later. But this is basically a clinical diagnosis which we should do on table. Rest we can follow with the patient,
Our
like
first goal
patient
is
can
to,
develop petechiae and all that.
To stabilize the patient. So with the help, inotropic support. Related to hypercapnia.
Yes. ABGs sometimes, but most of the time later on shows a respiratory kind of sometime alkalosis, sometime mixed picture, sometime acidosis as well. Yes. Sometime not immediately, but most of the time, sometime it's immediate effect, but most of the time it comes a little bit late.
What should we do when we are suspecting the patient having gas embolism?
Maintain the patient hyperbaric oxygen, inotropic support, exfoliate the pneumoperitoneum, patient position, left lateral position, large bore cannula to aspirate the gas embolism. Actually,
anticoagulation is the best way on table. And to stop the further surgery, if that is causing more harm, it's also one of the very important thing we should do on the table. And rest we can follow. If it's good if the surgery has already been done. If it's not done, then we have to abort it surgery if the tachycardia becomes significant enough.
हाँ मैडम सर्जरी का जो बंद करना है वो तो स्टेज ऑफ सर्जरी पे बिलोंग करेगा नहीं?
yes.
If we can do surgery on minimal pressure, then we can continue the surgery between 10 and 15 mercury pressure.
Okay.
So,
Sometimes we need to open the patient, but it happens in a very few cases as well. Very few cases.
if we can't abandon the patient, we can open the patient.
ठीक, चलें कंटिन्यू करें.
Asan?
Complications related to placement of trocar and various needle technique, injury to the gastrointestinal organ, injury to the intra-abdominal vessels, and bleeding at the sheath site. Bowel injury, thermal injury, full bowel necrosis may take up to 18 days, and post of unrecognized bowel trauma during surgery. Typical complications after robotic or laparoscopic surgery, we commonly see fever, abdominal pain, gut fullness, nausea, and vomiting. And the atypical low-grade fever, leukopenia, peritoneal, and related extreme pain at trocar site. Mostly, we see in the robotic patients complaint of pain abdomen. Sir, what is the reason? The Gares?
Pain in abdomen or pain in shoulder?
Pain abdomen. Mostly
because of pneumoperitoneum, there is diaphragmatic irritation, which radiates pain to the shoulder, and patient may complain of shoulder pain and hand pain till up till 2 weeks.
Sometime till 6 months as well. It
And
takes
if-
time.
Takes time. And if there are other things, if because of this pressure, there are multiple other things can happen post-operatively. The first thing is oligouria. Can anyone explain why it has happened? Why oligouria presents after pneumoperitoneum? Because there is compression of renal vasculature and in response to release of antidiuretic hormone.
But it,
So transient oligouria
it only happens if the pressure exceeds 15 and number one, and number two, it only happens when we have reached a critical diagnosis of compartment. Otherwise, it's a very rare phenomena to get oligouria during a laparoscopic and robotic surgeries.
But this thing, yes.
Abdominal pain is most of the main cause is the secretion that was excreted from the especially urine or blood that secreted the peritoneum. The most common cause of the abdominal pain in the patient of post-operative in robotic surgery or laparoscopic is the irritation of peritoneum. And you are like correctly right, said that the shoulder pain is due to the diaphragmatic irritation. But the common alias and pain in abdomen is a cause of irritation of peritoneum secondary to blood and other products like urine. कभी कभी यूरिन एक्स्ट्रावेजेंट हो जाता है या किडनी पंचर हो जाती है या पस पंचर पस जो है ना पायोनेफ्रोसिस की वजह से वो पस आती है. That is the cumbersome for the patient in post-operative period.
That's why retroperitoneal approach is favorable to avoid ileus post-operatively, because it avoid injuries to the gut and gut-related complication post-operatively. But retroperitoneal approach require expertise.
हम कर रहे हैं या नहीं? हमने अभी peds वाले करते हैं, हम नहीं करे adult वाले.
In pediatric, they
are
always
doing.
most commonly they use retroperitoneal approach.
तो हम अगर ये समझ रहे हैं तो why we are not doing this? अच्छा.
When peds में retroperitoneal approach जो है ना so quite easier है as compared to adult population के. तो ये भी एक पॉइंट है कि पीड्स में अगर और पेरिटोनियम उसमें पीड्स में न्यूमोपेरिटोनियम क्रिएट करना मसला होता है बच्चों के लिए और उससे ज्यादा कॉम्प्लिकेशन होती है, तो उसमें retroperitoneal approach is better than the peritoneal approach. But in adult population, retroperitoneal is quite difficult due to balloon dilatation and quite large size of the kidneys, and that is an issue. But yeah, we can approach, we can try, and we can do learn to how to do it via retroperitoneal approach.
Dr. Mother, people are doing retroperitoneal approach. Dr. Faiz,
Actually,
he
balloon
used to come in
use
the
of
conferences.
balloon. Sorry, use
Yes,
of balloon is not necessary. आप continue करो.
नहीं बताएं जी हम साहब.
The use of balloon for making space in retroperitoneum is not necessary because you do not need a thin film of balloon to dilate the retroperitoneal space. This is the air which is needed. And if you are not using air even, then it can still be possible to make space, but your camera will be blurred again and again because of the sweat and blood droplets dropping over it. So simple air will be enough for making space in retroperitoneum, and you will need to repeatedly clean your camera. Otherwise, you can do without balloon. Other thing is, I have never heard before that air is irritating the diaphragm and peritoneum. That's why 2-week pain. I don't have any idea about it. If there is any evidence regarding this, I will be happy to know about it. And remaining air remaining for 2 weeks into the peritoneal cavity is once again not understandable to me. I don't believe on it. Carbon dioxide remaining for 2 weeks inside the peritoneal cavity, I don't believe it.
No, but sometimes we also come to know that patients have abdominal pain after
This
surgery,
air
but
irritation was
abdomen is soft, non-tender, but they complain of pain.
that can't be related with air irritation. I have never heard about it. Never
Then what
read
is
about it.
the then reason
Because
for that?
carbon dioxide irritating intraperitoneal structures or peritoneum or diaphragm, I have never witnessed about it. I have no evidence
अरे
about
साहब
it.
GM साहब ने challenge कर दिया भाई.
We have performed laparoscopy for longer
Senior है, कर
durations,
सकते हैं.
but no patient complained of shoulder pain and peritoneal irritation or symptoms like that because of this residual air inside the body. Even simple atmospheric air is
What
present in
about wrist
retroperitoneum.
drop post-operatively? Why it is happened?
This can be neurological manifestation, neural nerve compression because of posture,
Why?
but peritoneal irritation with carbon dioxide is, I don't believe on.
चलें फिर इसको सॉर्ट आउट कर लेंगे आगे. इतनी स्लाइड्स और हैं क्योंकि अभी टाइम भी हो रहा है. आगे चलें. हाँ चलें ठीक सही है. फिर इसको सॉर्ट आउट करते हैं सर. बात को मैडम शीरी में बैठी हुई हैं, बताएंगी कुछ.
Early post-operative complications, bleeding, surgical site infections, particularly at core sites or incisions, pain and discomfort, atelectasis, pneumonia or respiratory distress due to decreased lung volumes. Deep vein thrombosis or pulmonary embolism can occur due to prolonged immobility. Post-operative ileus or bowel obstructive may occur. Electrolyte disturbance and early complication later to the surgical wound can include dehiscence of wound.
Thank you.